Hi, welcome to our lecture on head trauma. This is a very important high yield topic for your life and for boards. You're going to see that understanding the bleeds and the concussions and the contusions that happen around the head is a very important topic. It's one of the most frequently seen things when you do any sort of ER medicine, but recognizing the lesions that you are going to about to see today is crucial for your medical training. What we're going to do is you should have gone through some of the previous lectures that we've had, and we're going to apply the concepts that we have learned. We're also going to review some of the differential diagnosis. It's just not straightforward if something's a bleed or not, and we're going to have some take-home points, and hopefully that will wrap it up. I think this is a wonderful quote from Shakespeare, which is that not all that glitters is gold, and it really stands in this situation where we're going to see a lot of things that are hyperdense. Remember, I told you every time you saw hyperdensity in CT, you have to think about blood, but not all of it is blood, and so understanding blood, the types of bleeds, but also some of the differentials that you have to take into account is crucial when you do patient care, because what happens if you just assume something is a bleed and it's really not. So you at least have to think about that, even though you don't have to know all the differential diagnosis for now. Other things that you have to know is that with imaging, there's some contraindications for some of the images we're going to do. And today we're going to talk about contraindications for MRI. One of the biggest contraindications when you go to the next step after CT, which is MRI, is metal, right? Of course, not always is that you have a hammer stuck into your skull like this one, but when you have big pieces of metal, because you're in a magnet that is, remember, can be up to 60,000 times the magnetism of the Earth. If it moves, it becomes a projectile. It can heat up and it can have a worse lesion to your patient. You have to understand that some metal and metallic implants are important when you're doing these type of studies. Um, this comes from our previous lecture where we spoke about windowing, and one of the key things when we're doing trauma is to remember to always do the windows, and remember that we went through the windows, and this is the blood window, and how the blood window really allows you to see things that you would have otherwise likely missed if you were just looking at the soft tissue windows. And we spoke in the past about 4 windows that we do when we read CTs, which are the soft tissue window, the bone window, the blood window, and the stroke window, which is a very high contrasted gray white matter differentiation window. So dating hemorrhage in CT, that this is one of the things that we're going to start talking about, is kind of tough. Even though we have discussed that the density or the hyperdensity of the acute bleeds is because of iron, we also discussed in one of our previous videos that if the patient is anemic or the patient has replacement of blood by other products, sometimes it will not be as dense as you expect. And so dating a bleed is sometimes tough. Typically, very hyperdense bleeds tend to be acute, and as they become chronic, after a few weeks, they will start becoming very hypodense until they lose all the iron and they become completely hypodense. But dating them is not easy. For that, we utilize a little bit more MRI, and MRI uses kind of a different system for that. And since we also discussed that MRI goes from T1 to T2 to flare, and how these have different signal intensities when you're uh, depending on how you tweak, say, the magnet, it also changes the way that you see blood products. So it's different how you see blood products in an acute phase, in a subacute phase, in a late subacute phase or in a chronic phase. And MRI is much, much better than CT to date the bleeds. And this is important not only to know how to treat a patient, but for example, to know if a patient that was hospitalized fell, if, which component of the bleed was due to the fall and which was an old bleed that he already had. That's a case. When it comes to the ER, knowing of a patient that was unconscious, if this was something that happened now or was it old, or like in the case that we have here, we have different stages of blood. So let's kind of go back a bit in our MRI introduction lecture. And I hope that you also enjoy the basics MRI physics one that we had, where we're gonna see these images. And first thing we define when you see an M is to know if it's a CT or an MRI. You see that in all of the sequences we have, the bones are dark, so these are MRIs, and that in this one particularly, the white matter is white. So this is a T1. This one, the white matter is dark. It's a T2, same as this one, same as this one, same as the ones below. So what we have here are MRIs where you have a T1 and multiple flavors of T2, if you may. If you look at there's blood outside of the brain compartment here, and it's dark on T1. Here on the T2, it is bright, and it's slightly different shades of bright. It's not the same bright on the left than it is on the right side. But then when you do the flare, remember the flare, which is the T2 with the dark ventricles. Some of the blood is bright on one side, some is dark on the other, which is kind of tricky and it can become very problematic. And this special T2, which is the sequence that looks for hemosiderin, which is a susceptibility image, the hemosiderin looks dark and you see kind of a China ink effect of where you have hemosiderin deposits. So you have different stages of blood, and how does that happen? I love this diagram, and I took it from Radiopedia because it really kind of tells you how to stage blood. If you don't have to memorize it, there's a lot of things that radiologists use as a mnemotechnic for this one. I never remember which one is the right one. But with this graph, if you just have it around and available, you're going to remember it. So here you have the T1 intensities and here the T2 intensities. And what you see here is that the more you go towards the right on T2, the brighter it is. The more you go up high on the T1, the brighter it is. So when you have an acute bleed, when a patient just has an acute bleed, the first thing that will happen is that the blood is going to be iso intense on both T1 and T2. And that's because it has oxygenated hemoglobin. So you will not be able to differentiate blood from CSF, say. I mean, it's really not much. It's going to be super tough to see the blood because it's iso-intense to everything. Now, as it loses oxygenation, the blood becomes darker on T2. And that usually happens a day afterwards. So in the first day, it's iso. In the second day, the blood is actually dark on T2. So you start seeing something that is iso-intense on T1 and dark on T2. And that's where it's deoxyhemoglobin. And that usually only lasts for the first day and a half. Then the blood products start decomposing. And as they do that, it becomes something that we call methemoglobin. So when the methemoglobin starts, one of the coolest things about methemoglobin is it becomes bright on T1. So methemoglobin becomes bright on T1, it's still dark on T2. So in the first 2 to 7 days, the first week after the acute phase, the blood is going to be bright on T1 and it's going to be dark on T2. And it's mostly what is happening is that the iron is kind of trapped inside of the hemoglobin in the cell, so the T2 is really not reacting to it much. Once it gets extracellular, that methemoglobin, then it becomes bright on the T2. And right on T2 is the end of the first week to the end of the first month. And that's what we usually call subacute bleed. So it really tells you, you can know if the blood is in the first day, if it's in the late first week, or if it's in the late first month. And how is it going to see when you have extracellular methemoglobin? It's going to be right on both. Bright. And finally, very slowly, it loses its T1 signal until it becomes dark and dark, when all of the methemoglobin becomes hemosiderin. And then hemosiderin is going to be black, dark. And that's usually happens after the first month. So this is a great tool that we have of being able to do that. So this is the end of this very brief introduction to this class.